The apheresis. So today video is about the therapeutic plasma pheresis in pregnancy. As we all know, pregnancy poses unique challenges in autoimmune and hematological disorder where treatment must balance maternal benefit with the fetal safety. In select high-risk cases, TPE plays a vital role in maternal stabilization and fetal protection. So let's dive into the topic. Pregnancy is a state of profound physiological transformation. To support the developing fetus, nearly every system in the mother body adapts, sometimes mimicking some diseases, sometimes revealing it. So if we look for the cardiovascular symptom, there is increase in the cardiac output by 30 to 50%. There is increase in the stroke volume and heart rate. And in the systemic vascular resistance, the BP will decrease in the second trimester. So there are common physiological systolic murmur can be heard, peripheral edema can be seen, and there is supine hypotension. If we see in the respiratory system, the tidal volume, minute ventilation will increase. There is dyspnea, which is very common, which can be seen in the pregnant female. In the hematological system, if we see, there is increase in the plasma volume, increase in the RBC mass, so there is physiological anemia. So if a non-pregnant woman is having a plasma of 2.6 liters, the pregnant women will have 3.8 liters. There is result in a drop of HCT from 40 to 33% due to the dilution. We can also see hypocalcemia in some female. So when we are performing the TPE, the position is always slightly left, lateral decubitus position for these females. Females who are pregnant, there are some immunological changes. So successful pregnancy involves a complex interaction between the decidual immune cell and trophoblast cell, which allows the semi-allogenic fetus to evolve inside the mother body without being attacked by the maternal immune system. So HLA-G plays a key role in immunological mechanism that control maternal fetal tolerance during the pregnancy. So it will inhibit the cytotoxic activity of natural killer cells and downregulate the Th1 type cytokine production. So uterine NK cell, T cell, immature dendritic cell and macrophage help to regulate the uterine environment to maintain the successful pregnancy. Once the maternal fetal immune is disturbed, the pregnancy related disease with adverse pregnancy outcome for both mother and fetus can be seen. So pregnancy is associated with decrease in cellular immunity and increase in humoral immunity. Are the indications. So these are the indication where we can use the therapeutic plasma exchange. In thrombotic microangiopathy, when there is a placental cause like preeclampsia, HELLP syndrome, acute fatty liver, and the non-placental cause include your TTP, HUS, which is secondary to the drug or viral infection. Autoimmune causes like congenital heart block, multiple sclerosis, SLE, polyneuropathy, MG, neuromyelitis optica, PV, and in obstetric there is a red cell alloimmunization. Indication according to the ASFA guidelines. So there are various categories according to which we will classify. So if we are going with the obstetric cause, then there is red cell at alloimmunization. So for that, the TP category 3 is given. For HELLP syndrome, if postpartum, then category 3, and if it's antepartum, then category 4. For patient who are in preeclampsia, there is TPE we can do, but category is not yet specified. For HUS, the category 3 is given. For TTP, the category 1 is given. For antiphospholipid syndrome, the category 1 is given in the ASFA guidelines. For autoimmune cases, the congenital heart block or cardiac neonatal lupus, we can go with the immunoadsorption and TP both, and the category is 3. For multiple sclerosis, again both of them either we can use, and the category is 2. For SLE, category 2 according to the ASFA guideline. For Myasthenia gravis, category 1. For Neomyelitica optica, category 2. For hypertriglyceremic pancreatitis, category 3 is given. What is the recommendation for such patient? First is the positioning of the patient, which we have already told in the previous slides, that it is left lateral decubitus position. For adjustment of plasma volume, we have to do for the compensation for pregnancy. There should be routine monitoring of ionized calcium levels, and prophylactically we have to administer calcium gluconate during TPE. Monitoring of fibrinogen prior to the plasma exchange need to be done. There is continuous monitoring throughout the procedure. Consultation for OBS and gynec fetal medicine should be done. Determination of Rh negative status and administration of Rh immunoglobulin in case of Rh negative female. Fetal monitoring during or after plasma exchange session to be done. TP is more beneficial for pregnancy-specific diseases, as pharmacological treatment during the pregnancy are often hampered by the potential fetal toxicity. So there is one case. In this 22-year-old female presented with the 20 weeks of gestation with bilateral lower limb weakness for 3 months, and there is tingling paresthesia in bilateral lower limbs from the past 3 months associated with the obstetric complication hyperemesis gravidum, and then there is a loss of weight from 63 kgs to 44 kgs. Antibody screening shows negative and the diagnosis made is GBS. So for this treatment, we have done the plasmapheresis 5 cycles. There is injection of heparin 2500 VD is given, and injection optineuron is done. There is significant improvement seen in this female, and she was able to walk with the support, and paresthesia improved completely. And the outcome is she delivered a healthy male child with the normal delivery. Rh immunization, there is alloimmunization because of the Rh antibody. So we have to prophylactically given the dose of Rh immunoglobulin to the Rh negative mothers after 28 weeks of gestation, and it's a standardized practice so as to minimize the risk of HDFN in subsequent pregnancies. Plasma exchange conducted in Rh negative mother after 28 weeks will remove the prophylactically administered immunoglobulin. So conclusion of this is to add the additional dosing of the RHIG with involvement of obstetric or maternal fetal medicine person is required, and this will help to take the decision of whether to re-administer the immunoglobulin and to determine the reasonable dosage to give the Rh negative patient. In pregnancy, therapeutic plasma exchange become more than a medical procedure. It become bridge to survival for both mother and child. Thank you, and subscribe to Transfusion Vital for more trusted insight on apheresis in high-risk clinical scenarios.